Okay, self-assessment for this chapter, the patient with low mood. Multiple choice questions, let's start with them. The first question here is a 40-year-old woman who was started on a new medication a month ago presents with a 4-week history of depression. Which of the following might account for her presentation? Paracetamol, omeprazole, salbutamol, verapamil, and prednisolone. So the answer is obvious here. It is prednisolone. Why is that? It is the only medication listed here that is common with depression. You know, we are talking about steroids. Okay. Another question. A 35-year-old woman presents with mild depression. On examination, you notice midline neck swelling. What is the most appropriate initial step in patient care? Refer to psychiatry, check thyroid function, start an antidepressant, request a neck ultrasound, advise her to return if the symptoms persist. In this case, you should, because we are investigating about this symptom of depression, we should check thyroid function, of course. So, because, you know, the midline neck swelling may represent a goiter, for example. So, given the patient's symptoms are mild, there's time to check for thyroid function before starting treatment. And if she is hypothyroid, this should be treated first, which may normalize her mood without any need for antidepressants. Mild depression does not need referral to psychiatry, of course, if you are general practitioner. And of course, we may need the neck ultrasound. But thyroid function test would be the first thing to check here. And okay. So that's it. Another question. A 55-year-old man with no obvious psychiatric history presents with low mood, anhedonia, and fatigue. He has come for help as he believes his organs are rotting away. What is the most likely diagnosis? Bipolar disorder, schizoaffective disorder, schizophrenia, depressive episode with psychotic features, dementia. Okay, it's obvious here. We are talking about depressive episode with psychotic features. The patient here reports symptoms of depression alongside a mood congruent nihilistic delusion. Therefore, the most likely diagnosis is this: severe depressive episode with psychotic features, D. Okay. His lack of past psychiatric history makes schizoaffective disorder, schizophrenia, and bipolar disorders unlikely, as onset at his age is rare actually. Early onset dementia with behavioral and psychological symptoms is an unlikely possibility also. But to check for this, his cognition, we need to check cognition, family history, the ability to care for himself, and so on. Okay. And we should carefully check that and follow that up. Okay, question number 4. 25-year-old student turns up late for her appointment. She gives a 1-month history of low mood, anhedonia, and fatigue. What is the most appropriate area to cover in what remains of the appointment time? So there's no much time. So we're talking about priorities here. If the priority is to check for presence of biological symptoms of depression if you don't have much time, or drug history, or family history of mood disorder, suicidal ideation, or past medical history. Of course, we are talking about suicidal ideation. Suicidal ideation should be checked in everyone with a potential depressive episode. The other areas are all important but can be explored at later review. Okay. Another question here. A 19-year-old shop assistant presents in tears because her boyfriend broke up with her the day before. She did not sleep well last night and did not feel like having breakfast. She feels hopeless about the future and thinks she will never meet anyone else. She says she feels really depressed. What's the most appropriate initial step in patient care? A. Start an antidepressant. B. Refer to psychiatry. C. Ask her to complete a mood diary. D. Watchful waiting. E. Check for blood count, urea and electrolytes, liver function test, and thyroid function test. So, this patient is in a situational crisis, of course. It is likely that her symptoms will resolve spontaneously. So, that's why she needs reassurance and to be offered a follow-up appointment to check on her progress later on. She cannot be diagnosed with depression as her symptoms are present for less than 2 weeks, and she is unlikely to benefit from an antidepressant now. However, she may still be at risk of self-harm, of course, and should be screened for this. She does not need investigations, of course, for mood, as we didn't diagnose her with depression, and she does not need mood diary for her symptoms and so on. Okay, so that's it. Okay, the patient with low mood. Here we have some extended questions. Differential diagnosis of low mood. We have mild depressive episode, moderate depressive episode, severe depressive episode without psychotic features, severe depressive episode with psychotic features, recurrent depressive episode, dysthymia, bipolar affective disorder, schizoaffective disorder, low mood secondary to a general medical condition, low mood secondary to psychoactive substance use. And to remind you, we are talking about ICD-10 diagnoses. In DSM, the parallel diagnoses for these, for example, mild depressive episode would be major depressive episode, single episode with mild severity. Moderate depressive episode would be something like major depressive disorder with single episode and moderate severity, and so on. There are some differences here. Okay, for each of the following patients, select one the one most likely diagnosis from the list above. Okay, first case, a 40-year-old man feels he has been depressed for 20 years. He cannot recall a lengthy period of normal mood since his early adulthood. Okay, despite this, he is able to work as a supermarket manager, has a loving relationship with his wife, and reports that he quite enjoyed his last holiday in Tenerife. Anyways. Okay, so the patient here has subsyndromal symptoms of depression, actually, which emerged in adulthood and do not significantly interfere with his functioning. So that's it. That's why we may diagnose this patient with dysthymia. Okay. The second case, 42-year-old waitress has had low mood and lethargy for 3 weeks. She finds it harder than normal to remember her customers' orders. She thinks this is because she has never been an intelligent person. She is eating normally, sleeping well, and enjoyed going out to the movies last night. So the patient here has depression, of course, because the woman here has 2 out of 3 of the core symptoms of depression. She has poor concentration, poor self-esteem, of course, but there's no biological symptoms and so on. So she has depression, but because she is able to continue her normal activities, this will be just mild depressive episode. or in DSM-5 we call this major depressive episode with mild severity. Okay, another case. A 71-year-old widowed woman who lives alone is brought to the surgery by her neighbor. The neighbor is shocked because the patient put a rude note through his door telling him to get his drains unblocked in order to get rid of the stench in the street. No one else has noticed a bad smell. Before her husband died, the patient used to be very social and visited her neighbors frequently. On examination, she is unkempt and walks very slowly. When you ask her questions, she makes poor eye contact and does not answer for a long time. So this is also obvious. We have patient with... So let's just discuss the case here. So this woman has a clear change in functioning, of course, from her baseline. She has psychomotor retardation. And that may be olfactory hallucination, of course, the foul smell that leads to secondary delusions about the neighbors. Okay, and she is also at risk for depression because of the bereavement after her husband. Okay, so we are talking about severe depression, but not any severe depression. We are talking about severe depression with psychotic features. In the DSM-5, we would call this major depressive disorder with psychotic features. It is by definition severe, of course. Okay. Another case. A 35-year-old cashier presents to his general practitioner asking for a sick line. He feels he cannot continue at work because for the last month he has been in low in mood and finds himself becoming easily tired during his shifts. He is not enjoying talking with his colleagues as much as he used to. He finds himself waking at 5 a.m. He normally rises at 8 a.m. and lies in bed worrying about the day ahead. His mood is a bit better in the evenings. He has been eating poorly and lost a stone in weight over the last month. Okay, I think this patient has... Okay, he has 3 core symptoms of depression. The 3 core, all of them. And another symptoms like disturbed sleep and appetite. He is having great difficulty continuing his normal activities. That's why he is presented to the GP. So that would be moderate. Yes, moderate depression, because in mild depression there is some difficulty. In moderate depression there is significant difficulty in living. In severe, the life is stopped somehow, and there's so we are talking about moderate depression. Okay, another case. A 42-year-old construction worker reports intermittent low mood. Sometimes he is so low he is unable to go to work. On closer questioning, it seems it is mainly Mondays he misses, and the weekends he feels low. The problem has come on over the last year when he has been binge drinking at the weekends after his wife left him. The weekends, when he looks after his daughter, he does not drink and feels fine. So here we are talking about low mood secondary to psychoactive substance use. So that's it, because and that man would be diagnosed with what's called in DSM-5 something like harmful use of alcohol. Because we have low mood following excess use of alcohol. Okay, that has negative impact on mental health. Okay, so that's it. Another extended question about low mood secondary to general medical conditions. We have these conditions and we should, match them with the cases below. Huntington's disease, Parkinson, multiple sclerosis, cerebral tumor, Cushing syndrome, Addison disease, Conn syndrome, thrombocytopenia, hypothyroidism, and systemic lupus erythematosus. Okay, let's check the cases. A 52-year-old care assistant presents to her general practitioner with a 6-month history of low mood and fatigue. She complains she has put on a lot of weight recently despite no change in her diet or exercise. On examination, she is obese, hypertensive, and the blood pressure cuff leaves a bruise. So here we're talking about Cushing syndrome, of course. This is excess of cortisol. So, and these are the symptoms here. Depression, or even that may lead also to psychosis sometimes. But we have these clinical symptoms of obesity, hypertension, and easy bruising. Okay, another case. A 35-year-old traffic warden presents to his GP after he tripped over the curb and banged his knee. He also mentions a 3-month history of low mood. He is not sure why he tripped, but has been stumbling more often than he used to and has given up football. He does not drink. He thinks he may have a family history of depression because his father went into psychiatric hospital in his early 40s and died there 10 years later. So the history here is about, okay, let's say it like this. We have some kind of clumsiness and poor coordination. So we are talking about movement disorder, okay? And we have family history, so we are talking about something genetic in some kind, and that would be early in life. So the answer is obvious after these hints. We are talking about Huntington disease. It is an autosomal dominant neurodegenerative disorder, beginning in the basal ganglia. Depression is often an early symptom, of course, and here we can find this increase in clumsiness and poor coordination that can be subtle early features of the movement disorder, which progresses to marked ataxia with choreiform movements. Huntington's disease is not always talked about in families, and the description of the patient's father is more typical of the course of Huntington than of depression. Starts at 40s and, died 10 years later. Okay, so that's it. Another case. A 46-year-old florist presents because of the last 2 months she has felt tired all the time and low in mood. She feels ugly. Her hair never seems to be glossy anymore, and she thinks her skin is dry and flaky. On examination, her pulse is 42 regular. So this is obvious also. We are talking about hypothyroidism. Fatigue, low mood, dry hair, thin hair, dry skin, bradycardia. All of these are, some symptoms of hypothyroidism. Another case, a 26-year-old veterinary student presents with tingling in her left arm. She becomes tearful during the consultation, admitting she is finding the fourth year of her studies much more difficult than the previous year. You see, she attended 3 months ago with a sore eye and blurred vision, which resolved spontaneously. Okay, that's sad. Here we are talking about multiple sclerosis. Okay, we have neurological symptoms in more than one occasion, so this is multiple sclerosis, mostly. So let's talk about mental state examination in low mood. We have these findings like poor self-care, malingering, reduced range of reactivity, incongruous affect, low mood, psychomotor retardation, psychomotor agitation, marked appetite spas, negative cognition, hopelessness, complete anhedonia, and partial anhedonia. So for each of the following patients, select one clinical feature described from the list of options above. Okay. The first case here, 76-year-old widowed. Okay, what's that? A 76-year-old widowed retired headmistress is brought to accident and emergency by her family, who are concerned she has not been eating. She paces the cubicle, keeps buttoning and unbuttoning her coat, and does not sit down when offered a chair. So this is psychomotor agitation. This is a common feature of depression in older adults, of course. So, another case. A 44-year-old architect being treated for depression is upset because he has lost a contract after the company went bust. He says this means he will lose all his other contracts and never be asked to design another building. So this is some kind of negative cognition. Yes. When considering the loss of the contract and view himself and the future according to this is something from the to negative cognition about the future. So that's it. Okay. Another case. 22-year-old woman tells her general practitioner she has passed a recent exam but does not smile or appear pleased. Later she mentions she has broken up with her partner but does not look sad or relieved. She describes both things in a similar tone of speech. So this is reduced range of reactivity, or what we call as blunted affect. Okay, that's it. Another case. 36-year-old sales assistant attends his GP straight from work for a prescription of citalopram. He has greasy hair and stains on his shirt and is slightly malodorous. So, okay, this is so what's that? For self-image, malingering, reduced range. Okay, let's get back to the question. Sales assistant, greasy hair and stains on his shirt. Okay. Yeah, this is poor self-care. Poor self-care, of course. 5. A 55-year-old lorry driver tells his GP he has lost interest in everything he used to enjoy. He no longer plays darts or watches football, as he does not care who wins now. However, he did enjoy spending time with his grandson at the weekend. So this is anhedonia, but it's, yeah, partial anhedonia. So that's it.